who work in the Applied Research Collaboration for Greater Manchester. That's Professor Matt Sutton and Dr. Ruth Watkinson, because they're leading vital research looking at health inequalities and how we reduce their effects and how we reduce their occurrence, actually. But before we delve into their work, I just wanted to tell you a few things about what the University of Manchester's doing regarding health inequalities across the university. And I want to emphasise the unwavering support the university has for addressing social and health inequalities. And you may have seen that about 3 or 4 weeks ago, the University of Manchester came, I think, second in the world for its contribution to social responsibility and addressing the Millennium Development Goals. So we're very, very proud of that. And I think the work that the university is now doing to look more closely at health inequalities and try and find a response to health inequalities is just a further example of the university's commitment to those goals. So to put some of that in a bit of historical context, the university has a very strong record of revolutionary healthcare firsts, like the first NHS hospital and the first nursing degree in England. So time and again, we've shown how our health innovations can have a transformative effect on health for all. And the whole of society. Now, health inequalities are a major issue, and they are an issue both at an individual level and a societal level, and in fact at a neighbourhood and community level. And the more socially disadvantaged work together and have a stark economic effect, not just an effect on people's health or their longevity. So we know that poorer health leads to poorer economic productivity. So we need to, there's lots of reasons why we need to address health inequalities, but the Northwest is an area of England with some of the worst health and also the lowest economic productivity. And there's lots of very good reasons why we need to address both those things for the greater good. So the University of Manchester is uniquely placed to take on this challenge. And in fact, we're already doing so. We've been mapping the research on health inequalities that is being undergone across the university. And we can say that there's an awful lot of research in all 3 faculties, not just in humanities, not just in biology, medicine and health, where you would expect this research to be going on, but also in the Faculty of Science and Engineering, where they're doing an awful lot of research on air pollution and the unequal way that air pollution is distributed to make the health of those people who were already disadvantaged even worse. So there's lots of really good stuff going on across the university. And I think because of the health and care and academic ecosystem in which we all live and work in Greater Manchester, we are uniquely placed, partly also due to our partnerships with the local authorities, to make a real difference and translate innovation into actual breakthrough solutions to these real world problems. And the scale and the diversity of the people who we work with also means that we can make a difference, both regionally, nationally and globally. We can test things out in Greater Manchester that can make a difference elsewhere. And we can actually, through our international partnerships, learn a lot about what happens elsewhere in the world that we can test out in Greater Manchester. So there's lots of opportunity to do more. Now, our community of supporters are already making a huge difference to this work. So just recently, we have the building completed on Manchester's world-class new Cancer Research Centre at the Patterson Institute down at the Christie Hospital. And that's one of the largest in Europe and has been This incredible facility will bring together patients, clinicians and researchers, and has been specially designed to speed up research programs and speed up the pace that we can use those innovations and apply them in practice and policy. So it's just a fantastic opportunity and just one example of how our alumni, our donors and our volunteers are making a real difference to health research. And we're incredibly grateful to everyone who supported this important project. And if you'd like to find out how you could help with projects like these, please speak to a member of our team. So we hope you'll feel proud of what the university is doing in this regard, and we really look forward to sharing it with you. So I'm now going to move to introduce the first of our speakers. The speakers are going to follow on one from the other, and then we're going to have the questions all together after both talks. So if you have a question that arises during the first presentation, hang on to it, write it down, and we'll come back to the questions after Matt's spoken. So I'm going to introduce Dr. Ruth Watkinson to you first. So Ruth is a research fellow, as I said earlier, in the NIHR Applied Research Collaboration for Greater Manchester here at the university. And her research uses large data sets to identify and understand socio-demographic health inequalities. And she's going to illustrate that to you brilliantly this evening. So her current projects include investigation of inequalities in vaccine uptake between socio-economic and ethnic groups, and inequalities in mental health outcomes amongst the LGBTQ+ community. Before joining the University of Manchester, Ruth worked in biomedical research in Cambridge and New York and studied for an MSc in public health at the London School of Hygiene and Tropical Medicine. And I'm very delighted to introduce Ruth to you now. Thank you, Ruth.
Okay, thanks Nikki, and hello everyone. So I'm going to talk about widening inequalities in flu vaccine uptake since the start of the COVID pandemic. So this is part of a bigger project, which is the Greater Manchester Vaccine Equity Project. And this is a fairly big mixed methods project where we're trying to understand inequalities linked to COVID and to vaccination within Greater Manchester. So it has this local Greater Manchester focus, so all the study participants live in the region, and we're using a local health and care data set, the Greater Manchester Care Record. So just to give you an overview, the first part of this project, we found really wide ethnic inequalities in COVID vaccine uptake in Greater Manchester. Then we've also got a couple of components that used focus groups and interviews to explore opinions and attitudes towards vaccination, and also to dig a bit deeper into community experiences during the pandemic. The last bit is what I'm going to focus on today, and that's looking at whether the context of the COVID pandemic changed the uptake of non-COVID, so routine vaccinations. And I'm focusing on the flu vaccine uptake here. So just really quickly, a bit of background to flu vaccination. So I'm sure you're all aware that flu infection can lead to really severe outcomes with morbidity and mortality, and it's one of the big drivers of winter healthcare pressures as well. So there's annual flu vaccination available, which can protect against some of these severe outcomes. And it's available free on the NHS for groups who are at high risk. And one of those groups is older adults, so generally people aged 65+, and that's the group that I'm going to focus on in this talk. So in terms of how people access flu vaccination, it can often be via a GP appointment or alternatively at a community pharmacy. So why did we think that the COVID pandemic might affect uptake of flu vaccination? What's kind of the rationale for this research question? So one of the big kind of groups of factors is that there were differences in access to vaccination during the pandemic. So, I mean, it hardly needs saying, but we're all aware just how widespread and unequal the disruption to all kinds of healthcare services was during the pandemic. And of course, we've also got an ongoing crisis in access to GP appointments. And again, that's quite unequal between areas, so there's potential implications for inequalities here. There were also a number of changes to how flu vaccines were delivered and available during the pandemic. So, for example, some people were able to get a flu vaccine at the newly set up COVID mass vaccination centres. And in some cases, there was also options for co-administration, so people could get their flu vaccine at the same time as a COVID booster. There was also a change in the eligibility. So normally it would be older adults aged 65 plus who are invited for vaccination. But during the pandemic, this age restriction was dropped to 50 plus. And that did actually lead to some initial shortages in supply. And again, this was differential between areas, so potential inequalities implications. The other side of vaccine uptake, of course, is not just how do you access it, but do you want to access it? So there may also have been changes in people's attitudes towards flu vaccination. So potentially this could have changed because the COVID pandemic made lots of people more aware of their health and health risks, and potentially the risks of getting flu and COVID together at the same time. So it might have increased people's perceived need for vaccination. Of course, there was also the very high-profile COVID mass vaccination campaigns, which came with extensive public health messaging about the benefits of vaccination, encouraging us all to go and get vaccinated. So that might have shifted opinions about vaccination in general. At the same time, though, there was also big increases in anti-vax sentiments and misinformation and disinformation, particularly shared online. So that could also have shifted attitudes in the opposite direction. And potentially these effects were differently felt across different social groups. I think also as well, there was some increased public awareness of the potential for rare side effects from vaccination. After a couple of the COVID vaccines were restricted by age or suspended in some countries because of the links to blood clots and myocarditis. So that's the rationale. Coming on to the approach. So I mentioned briefly that we use this Greater Manchester Care Record. So this is quite a novel data source, and it brings together electronic health data from GPs, hospitals, and some COVID data across the region of Greater Manchester. So it's got almost population level coverage. It's about 2.8 million people. And it was really developed and kind of accelerated during the pandemic to allow better data sharing between NHS organisations. This was to kind of directly improve patient care. But at the same time, it was also made available in an anonymised format for researchers who were doing COVID-related research to help with the pandemic response. So one of the quite novel things about this is that it was available to researchers almost in real time, which enabled us to kind of really, as inequalities were emerging, analyse them and then feed that information back to people who were working in the local COVID and vaccination response. So as well as working with kind of stakeholders in the local health and care system, we also worked with a group of public contributors, and they represented a diverse range of local communities. And it was really important to have their voices included, and it really helped us understand better some of the context around these inequalities that we were seeing. So now I'm going to move into some of the results. So first, I'm just showing you what happened overall with flu vaccine uptake in the years before and then immediately after the pandemic. So what I'm showing here in this heat map is up the side, you have each age group, and across the bottom, it's each year. And the darker blues indicate there was higher vaccine uptake. So amongst older adults, there was generally higher uptake in the older age groups. And if you look to the right of that dashed line, which indicates the start of the pandemic, you can see there was a jump in uptake. It gets darker blue. So by 2021-22, about 80% of people aged 75 plus did take up the flu vaccination. But we know from a lot of previous work that things like high overall vaccine uptake can hide big inequalities. So we know there's major inequalities across Greater Manchester. This map shows the region coloured by area level income deprivation or poverty. And you can see there are some of the most deprived, but also some of the least deprived areas across the country. So what we did next is to look at just within the 10% most deprived neighbourhoods and then separately the 10% least deprived neighbourhoods, what was flu vaccine uptake like in each year. So you can see that even before the pandemic, there was a pretty substantial gap here, about 8 to 10 percentage points difference between the most and least deprived. And that was fairly stable over those last 5 years. If we then look what happened since the start of the COVID pandemic, that uptake gap has nearly doubled. So although in some areas uptake is now about 80%, it's only about 65% in the most deprived areas. Another way of looking at this is to take all of the data and use a statistical model to look at what happened across each of the different neighbourhoods. So I'm showing here the least deprived neighbourhoods are set to 1, and everything else is relative to that. So numbers below 1 indicate lower uptake. You can see that things were relatively stable prior to the pandemic, although there were these pre-existing inequalities. But after the start of the pandemic, the inequalities increased across the whole social gradient. This isn't just a case of inequalities at the extremes. You can also see that the gaps got wider in the second year of the pandemic, which raises the question of what's the ongoing situation going to be. So just to conclude then, we found that although flu vaccine uptake did increase since the start of the pandemic, inequalities also widened. This is likely due to a combination of changes in vaccine access and attitudes towards vaccination. And it's going to be really important to understand which of these factors represent ongoing changes and what the implications might be for future inequalities and also potentially for other routine vaccinations. Of course, all of this is important because inequalities in vaccine uptake will leave some individuals and some communities more exposed to severe outcomes from flu, and that's likely to translate into inequalities in hospitalizations and deaths. So I just want to highlight that this has been a big team effort. We've had input from researchers across the university and great support from the public engagement team. We've also had brilliant input from our public advisory group and, of course, the Greater Manchester Care Record team and all the patients whose routine care data enable this kind of research. Thank you.
Thanks very much, Ruth. I think you'll all agree with me that that was a very clear presentation. Thank you so much. We'll have lots of questions and time for discussion after Matt's spoken. So I'm going to introduce now Professor Matt Sutton. So Matt has been a chair in health economics at the University of Manchester since 2008, and he is currently the Deputy Director of the Applied Research Collaboration that I lead and that we're all working in. He's also co-director of the NIHR, that's our big funder for this kind of research in England, the NIHR Policy Research Unit in Health and Social Care Systems and Commissioning. Matt applies econometric methods to national surveys and administrative data sets related to the financing and organisation of healthcare, the healthcare workforce, and influences on health and health behaviours. And he's been an NIHR senior investigator since 2016 and a member of the NHS Advisory Committee on resource allocation since 2017. Matt, thank you.
Thank you. Can I check the microphone's working? Okay, great. Thanks. Okay, great. Let me get my water. I'm going to talk to you about our attempt to look at what we can learn from the devolution of powers to Greater Manchester. Its relevance for health inequalities being part of the reason why Greater Manchester was given devolved powers is because of its very poor record, both economically and in health terms. So I'm mainly going to talk about talk about life expectancy, and just as a background here, so life expectancy at birth in Greater Manchester is 1.8 years shorter than the national average. So There is clearly a major problem with the health of Greater Manchester citizens, and I'm going to look at whether giving Greater Manchester authorities more discretion over what to do led to any improvements in their health. I am covering the period before Ruth started speaking, so I am covering the period up to the start of the COVID pandemic. I'm looking at that short window when we had devolution and COVID had not yet entered our lives. Very topical given George Osborne's appearance today. These are the two sort of big devolution moments for Greater Manchester. So first of all, kind of in late 2014, there's a new devolution deal, which is covering areas other than health, or rather covering areas other than health and social care. So there's an agreement that there will be more decision-making and budgetary powers for the Greater Manchester authorities in areas like housing and employment, etc. And those powers have generally extended over time. So Manchester is always remaining slightly ahead of the curve. Other places have had devolved powers, but Manchester always more than others. And then just a few months later, and now we finally have a woman on the panel here, as you will notice. So the health and social care deal is signed, and this is unique to Manchester. So Manchester is given more discretion of powers over its health and social care budget. Now this one's much more of what's been described as a soft devolution deal. So there was transformation funding being given at the time, so sort of additional funds for transforming the health and social care system. And Greater Manchester was given control over that at a regional level. So in other places, it was given directly to health organisations, and they tended to use it to fill provider deficits, whereas Greater Manchester got the opportunity to use a little bit more strategically. And it was through these kind of region-wide partnership boards that decision-making took place. It was very criticised at the time in some circles because it wasn't really devolution, in the sense that the local NHS organisations still remained under the control of the centre. So the financial flows were the same, the rules about targets and the rules about payment systems all stayed kind of subject to central control. So this was a kind of much more sort of gentle, the region had an influence over what the organisations could do. Now, we've been sort of researching the impact of that for a very long time. It's funded by the Health Foundation, one of the other major funders of our work, a charity based in London. And we've done this work over 3 phases. I'm going to cover the last phase, but at the beginning we started examining kind of what did devolution really mean. So that was more interviews and observing meetings. We then produced a first estimate of what the short-term impact of that had been, but we have now completed the evaluation of the longer-term impact. And as I say, that covers the period up until March 2020. It is a huge effort. All my colleagues are listed here, so I'm representing a large team here. The only thing I just wanted to say was, well, why do you need so many of you and why does it take you so long? This is an illustration of the World Health Organization's way in which they think about health system performance. You won't be able to read the details, so apologies for that, but in some sense it was the sort of scale of the diagram I wanted to use as the example. But the point that they make is that when we think about health systems, they are incredibly complex and multi-factored and multi-influenced things. So we have kind of functions of the system on the left-hand side. We have what we might think of as intermediate objectives, like giving people access to services. And then we can think about its final goals about kind of health outcomes, patient experience. But all of this is sort of taking place within what we now refer to as the social determinants of health. So that's how important things that aren't the NHS are for our health. And so it's things about our behaviours, our personal resources, and the physical environment in which we live. And then wrapped around the whole of that is then your political context, your cultural context, your demographic context, and the economic context. So it's a very, very difficult thing to try and understand, if you pull one lever, what's the outcome, because there are so many moving parts. But let's ignore that and let's try and get at an effect of devolution on a single measure. So can we get a summary statistic of what the effect of devolution was? And so that's what we did in this fairly recent paper. So was there an effect of devolution on a single measure of the population's health, which is its life expectancy at birth? And life expectancy basically looks at mortality rates at different ages and tries to summarize if a population was subject to those mortality rates throughout its life, how long would you expect it to live? We're using a method called generalized synthetic control, which I'll show you graphically in a minute. And the result that we found is that there was almost a 0.2 year higher level of life expectancy in Greater Manchester after those powers were devolved. And 0.2 years might sound very small, but bear in mind that over this period, there's only a 0.1 increase in life expectancy across the country as a whole. So a 0.2 larger increase is quite a substantial difference that happened in Greater Manchester around this time. And I'll also refer a bit later to the fact that the effects were larger for men than they were for women. And they generally applied across the whole of Greater Manchester. There are 10 localities. They generally applied across all of those, but there are some exceptions, and I'll talk about those. But the other thing we found is that those changes were larger in the most deprived parts of Greater Manchester, which Ruth has shown you, but also those areas which started off with lower levels of life expectancy to start with. So this kind of giving of discretionary powers within Greater Manchester does appear to have produced targeted increases in the places where those increases were needed the most. And that fits with the narrative around if you devolve power and discretion down to the local level, the local decision makers perhaps do know more about the needs of the local areas rather than trying to control this from the centre. So let's see if I can convince you that the 0.2 magic number is real. So this is what's happening in Greater Manchester in terms of its life expectancy over time. And what we see is a steady increase in life expectancy until around, 2012, something like that. There's then a flatlining, which I'll talk about a bit more in a minute. And then when devolution comes in, which is the vertical line here, we start to see some evidence of an increase in life expectancy towards the end of the period. Okay, well, I said earlier that Greater Manchester's record is appalling in comparison to the rest of England. So if we put the rest of England's life expectancy on here, you can see somewhat of a similar trend, but from a much higher level. And so kind of how might we say, try and sort of disentangle what the effect of Greater Manchester is compared to the rest of England. Well, the first thing we might say is, well, it's not really very suitable to compare to the southeast because that's a very different place. So maybe we should compare it to other places which had a terrible life expectancy record beforehand. So here I've kind of replaced the line with some other places which had pretty poor life expectancy. And now you start to see some evidence that towards the end, Greater Manchester starts to catch up. It's still bottom of the league, but it's not quite so bad as it used to be. Of course, still it remains the case that you have to find somewhere else in the rest of England that you can say is like Greater Manchester. And what we've ended up doing is essentially constructing an alternative version of Greater Manchester from the other parts of the country by trying to find places that exactly track what was happening in Greater Manchester before devolution came along. So we do this using a statistical counterfactual, and hopefully you can sort of make out here on the left-hand side, this is the trend that's happening in Greater Manchester, and actually they're so indistinguishable. The dotted line here is this constructed counterfactual, so a little bit of some other places from around the country, and it perfectly tracks exactly the same trend. Whereas when devolution comes in, what we see is that the comparators actually drop in life expectancy. And this was something that had been seen around the time, that around the mid kind of 2010s, some areas were experiencing drops in life expectancy. And actually what seems to happen here is that devolution managed to protect Manchester from that drop initially. So whilst other comparable areas were dropping in life expectancy, Greater Manchester kept life expectancy flat, and then it has then produced larger increases than we've seen in the rest of the country as the rest of the country starts to recover. I said we kind of looked at whether there's variability in this across the patch, and here I've kind of taken the most deprived bits of Greater Manchester on the far left-hand side and the least deprived localities, so the local authorities on the right-hand side. So Trafford is the least deprived local authority. And you can see a bit of a pattern here, but it's particularly remarkable that basically Manchester, the most deprived part of Greater Manchester, and Salford, the third most deprived, are the ones which have the most substantial increases in life expectancy above what we would have expected then to have happened there. Other places like Rochdale and Oldham, there's virtually no change, so they have essentially continued pretty much as you would have expected if we'd not had devolution. So I'll kind of summarize where we are here. So this sort of our attempt to sort of summarize, has devolution been good for population health, and reduce it down to one measure, has produced quite a substantial improvement in life expectancy over what we would have expected. And what was nice to see is that those gains were particularly large in the more deprived local authorities. And so this, in a sense, has been a success. And it's one of the few successes we have of interventions to try and reduce inequalities. Devolution in itself appeared to do that up until the start of the pandemic. Now, as I say, devolution was a very complex intervention in that sense. You have a health and social care devolution deal, but you also had a series of other things being devolved, which themselves are very important in influencing people's health. So changes in housing, changes in transport are themselves very important for our health. And so we're unable to say which bit of devolution mattered, but that kind of general process of devolved powers has worked. And I guess questions which you'll probably have already spotted, but just the ones for us are kind of, will we ever understand what the specific causes were? We have tried very hard to get at those, but I think we're left with, to some extent, saying this devolution initiative has improved health. Why have the differences been by gender and by locality? So we've seen that happening, but is there any way in which we can justify that? And then, of course, the really important question about, was the region prepared for the pandemic? And did the kind of more discretion, more local powers allow Greater Manchester to do better than the other areas in terms of their response to the pandemic? And that we still have yet to find out. So.
Thanks very much, Matt. I think you'll agree, another very, very clear presentation. So do you want to have a seat? Yeah. The plan is we're going to do a bit of a Q&A now. So I'm going to kick things off with a couple of questions, but I am very keen to preserve sufficient time for people in the audience to ask questions as well. Okay, so I'll just kick things off. And I can fill in if you're a bit reluctant, but I would really rather people ask questions from the floor. So firstly, for Ruth, have you got your microphones on, by the way? Yeah. Good, yeah. So at face value, flu vaccination is a tool that has widened inequalities. So what would be the best policy response to that?
Yeah, it's a good question. I guess to some extent, almost all interventions do tend to widen inequalities. It's the rare examples, like Matt was saying, that actually manage to counter that kind of general direction. But of course, it doesn't mean we shouldn't intervene. But it does mean that we need to think carefully about how the resources for the whole flu vaccination budget are spent. So we had some great conversations with local public health teams across Greater Manchester, and a lot of the things they were saying was, yes, we can get more people vaccinated, but some people it's very cheap to vaccinate, and some people it's very expensive to vaccinate. And at the moment, the funding doesn't account for that, or certainly doesn't enough. So some people, if you say you're eligible for vaccination, they'll queue up. And other people, it's going to need maybe a conversation with a trusted GP, or some extra encouragement, or there are various interventions where people have managed to increase vaccine uptake, but it takes effort and it takes time and it takes money. And I guess it's reallocating how that money is distributed that could make a difference.
Thank you. And I guess there may well be another pandemic round the corner. We have to expect that there might be some kind of pandemic round the corner. But in a way, we've got the constant pandemic of health inequalities due to a range of different factors. So we kind of need to be acting on this all the time rather than waiting for something to come along. So is there any particular learning, either from your research or other research that you know about, that we can be putting into practice now that will make communities more resilient or less susceptible to these external influences like a horrendous pandemic? I mean, what can we be doing now, do you think?
Yeah, I guess the things that would make a difference long term and the things that would change readiness and resilience are going to be kind of the bigger structural changes. It's going to be reorganizing the distribution of wealth, the distribution of power, all of these things across communities, making sure people have the money that they need, making sure communities have the money that they need, that there's the infrastructure and services, and making that more equal across society would mean that all communities were better prepared for any future kind of health shocks.
Final one from me for you, Ruth. Do you think a lot of what's needed in that regard is also about, I say, education? I mean, education is a really important instrument to help all sorts of communities develop and get the most out of everything else that's on offer. But do we need to do something slightly differently about education as well, in terms of having our public organisations having more close relationships with our communities, maybe, so that, you know, we're not going in when it's too late, but, you know, that kind of lack of trust is, we should be chipping away at that all the time through better education and better relationships, maybe?
Yeah, I think the relationships and the trust is key. And that, again, talking to some of the public health teams in Greater Manchester, it is something that they're trying to focus on. I think COVID has really highlighted that and what's needed there. So we were having some vaccine conversations, and I think it was the public health team in Rochdale were saying that actually they've decided for now to take the vaccine conversation off the table and to say instead, what can we do to support you this winter? What do you need? What are you struggling most with? And if along the way, also, would you like to get vaccinated? It could protect your health, comes into that, that's great. But let's start with focusing on what do people need? What do people want? Stop telling people what you want them to do and kind of give that power back and build that trust. And I think that is probably the way to go.
Thank you. So hopefully that's maybe made you think of lots of questions that we'll come to you in a moment. Thanks, Ruth. So to Matt now, a controversial question. Is increasing life expectancy always a good thing?
Yes. Let me see how I can say this politely. So I guess when you see a region that is so far behind the rest of the country, so I think this kind of 1.8 years gap is a motivation enough. I think to say that Greater Manchester didn't need to place a priority on improving its life expectancy kind of would have been the mistake. So I think kind of aiming to catch up with the rest of the country should be the sort of least of our ambitions.
Okay, but no, I'm not disputing that, I guess. But I think you've also looked at healthy life expectancy, have you? Or are you planning to?
Yeah, no, so as best we can, we sort of try and adjust for how each of those years, the sort of a quality adjustment for each of those years. We don't see such a large effect there, which suggests that the gains in Manchester might have been around reducing mortality, but not necessarily about kind of improving quality of life for people who were alive.
So I'm very interested in the differential effects in the different localities across Greater Manchester, and really heartening to see some of the most deprived areas had a really bigger increase in life expectancy, which is great. But the Oldham and Rochdale areas are really interesting. They seem to be outliers in that regard. And have you any sense of what's going on there, or have you got ways of kind of digging into those localities to try and understand that?
Yeah. So the first time we presented it, actually, people sort of said, well, that's a sort of not peripheral issue, it's a periphery issue. Yeah, that actually the two areas that really seem to have benefited most from devolution were the two kind of cities, so essentially Manchester and Salford. And so kind of the question was sort of, is it because they were more integral to the Greater Manchester power than the sort of more peripheral areas? The other thing was the deaths, the reduction in deaths are primarily in kind of alcohol misuse and then violent crime and in air pollution. So I guess what it may be we're seeing is that those were the areas which historically had the highest problems with alcohol misuse, with air pollution deaths, and deaths due to violence. And so that's perhaps what the effect was.
That's really interesting. Thank you. So have we got some questions from the floor? And we've got some roving mics coming around, and they're all in the middle. Starting at the front and working backwards to Malcolm there. It's on if it's red.
It's on. Is it? Yes, so. Okay. Tony Brown. A question for Matt, really. Did you try and look at the economic well-being of these places that you looked at? I'm thinking of Salford, for example, that's had a major redevelopment. Manchester, again, major redevelopment, whereas Rochdale and Oldham tend to be stuck in the 19th century almost as far as economic development goes. I wondered if you tried to factor that in by looking at the economic indicators for each area.
Yeah, and actually the whole of Greater Manchester, so again, over this period, so bear in mind this chair is a little bit wobbly, so I'm hoping I'm not going to end up on the floor. Over this period, actually Greater Manchester's economic well-being didn't improve as much as you would expected it to, given the trajectory it was on before. So again, that's sort of comparing it to other places in the country. Actually, Greater Manchester as a whole didn't improve as much as we would have expected it to.
I mean, relative to each other.
Yeah.
If you look at, certainly Salford did a lot better than Rochdale.
Yeah. So the short answer to your question, I'm trying. We tried to look to see whether that would account for the whole of the effect, and the answer is no. It's part of the story, but not the whole of the effect. So yeah.
I mean, going back to that WHO framework, it's a really complex system, isn't it? So you kind of, really hard to tease out the effect. So there was a couple in the middle. So there's the chap in the green T-shirt and then the chap in front of him as well, after you, sir. So after you, if you just pass it ahead.
Okay, I've got two questions. One for Ruth, which is the university doing anything about inciting the revolutionary change that you want to see? And a much more academic question for Matt. How do you distinguish the effects of migration in Manchester? The poor parts of Manchester and Salford have been repopulated, many of them, by much richer inhabitants. I wonder if the poor people who live in Newton Heath will die just as early as they did before, and they've been replaced by different people in other places.
Yeah. And so the short answer to your question is we haven't and we couldn't. But I think that's a real possibility. Yeah.
But related to that, I think is a question about neighbourhoods versus... And it's a bit like... So Ruth drilled down to a much smaller area where even within localities you will see... It's the chap in front of you there. You will see big differences within a locality between different neighbourhoods. I think that's sort of what you're getting at. That in a locality there'll be rich and you haven't drilled down to that level of.
No, but I think also we're not sort of following a single population over time. It's we're defining the area and the people who live there as the. Yeah. No,
Thank you. So you, sir.
Well, when I retired from work, for some years I was a city councillor in Manchester. For 4 years, chairing the Health Scrutiny Committee. And what I'd like to ask, I stood down in 2010, so I'm out of touch, but to what extent did you have any involvement in doing presentations at those committees, and developing closer relations with officers? Also, quite And the meetings are public, they're on the council's website. Quite apart from the general meetings, there also tend to be what are called ward coordination meetings in particular areas which bring a number of districts together. And at those meetings as well, health issues do arise and discuss. And, you know, I think there's a good deal of mileage in building up close relations with those organisations.
Yeah, so Nikki, I think, will want to probably say something as well. But let me just, I suppose, because we were being funded by an independent charity and they wanted to make sure we did an independent evaluation, we had this sort of we had to carefully manage the relationship in terms of, so the start of the evaluation, we were definitely just observers. So we would go to meetings exactly like that and observe what was happening and kind of analyse how devolution was being put into place. Then we kind of entered a period where we basically went away and analysed our data, trying to make sure we weren't kind of influenced by people who wanted to see particular results. Now the results are in the public domain. We've been doing quite a lot of engagement with those, kind of not specifically the committee you've talked about, but actually quite a lot with the local partnership about kind of what we're finding, what the lessons might be, and that sort of work. But I think you always do have to sort of slightly manage your distance to make sure that you produce something which you're comfortable is independent of influence.
I mean, I think it's a really good question, and it depends on the nature of the work that you're doing. So what we're very, very clear about as a group of health researchers and beyond the health researchers in a civic university is that one of our primary considerations is to do research that can benefit the city regions communities. And so one of the things we're doing much more of nowadays, I mean, Matt would still carry on doing independent evaluations of this kind because that independence is really important. But also we can do much more research as partners with the combined authority, with the localities, with the NHS for Greater Manchester, which is what the latest iteration of health and social care devolution is, and we are doing. So we're doing that research very much in partnership. We have regular meetings where we talk about what their priorities are and how we can act in some ways in service of those, using our academic lens without going too native, because I think if you get too, much a part of it, you lose that independence. So it is quite a tightrope. But that's a great question. So I'm going to pass to Malcolm now, and then we've got a question here at the front, and then and then some more up there. But I'll be led by the people who are pulling my strings. But over to you.
Thanks, Malcolm Oswald, and thanks to both Ruth and Matt. It's an important subject, health inequalities, and talks are very good. So thank you. It may sound, it's not just a health economic question, it's also an ethical question, so Ruth might like to come back on it as well. So we have a limited budget in Manchester, everywhere in the world, to spend on our healthcare, and we want to get as many good quality life years as we can out of it. Should we be trading off some of that overall health to reduce those health inequalities in certain areas so that we might sacrifice, if you like, the amount of good we can do throughout Greater Manchester as a sort of a total to improve the health of places like Oldham and Rochdale?
That sounds like a question for a health economist, really, Matt.
So, yes. And Nikki said in my introduction, so I'm one of the members of the Advisory Committee on Resource Allocation. I think that's what we think our purpose is actually reallocating the NHS budget so that we reduce inequalities in health across the country. So yes, I think you do it through the resources that you put in place rather than kind of taking health away from others. But I think certainly, the principle is that you put the money where you get the largest return, and the largest return is generally in the areas that have got the least.
Ruth, do you want to add anything to that?
I think I just agree, that there will have to be a reallocation if we want to improve health inequalities, and there has to be a cost. But
thank you. Question over here.
I've got two things. First, we'll go back to something that Matt said earlier about that you've not been tracking, obviously, the same cohort of people in those areas. Do there exist any data sets that could be delved into? Like, I'm thinking like UK Biobank, although that's quite perhaps a bit of a niche group of people. We know that anyway. But are there any data sets that we could delve into where we do try and track the same people, even if they move within localities, because obviously the NHS record is tracked in some way.
Yeah.
And the other thing was just about, the gentleman talked about Rochdale and etc. being very different to Manchester and Salford. As you can see, I'm sitting in a wheelchair. I'm a very frequent user of the NHS, and I go to various hospitals, and I can tell you now the service I get in Manchester Royal Infirmary in a modern hospital is second to none. When I go to Bolton Hospital, I'm sorry if there's anybody here who works at Bolton Hospital, but it's like going back into another era. And I also go to Lee Infirmary, which if anybody's been to Lee Infirmary, it is the very image of an infirmary from about 1823, and it hasn't changed since. It's really poorly resourced, it's ancient, it's falling to bits, literally falling to bits. So it wouldn't surprise me if, you go to Salford Royal, you go to MRI, it's pretty much brand new, the whole place is brand new, or it's being replaced. Whereas in Bolton and Lee, they're not being replaced, they're cobbling together really ancient Victorian buildings, and so they haven't got the money isn't feeding through into those places, and I'm sure, I've not been to Rochdale or Oldham, but I'm pretty certain they're in a similar kind of position.
Thank you.
I mean, I think the point you make is really important. I think you do tend to always get that pull to centralisation, that the best facilities are in the centre, and the more that they grow, the more they... So I think that point's really well made. The question about the data is a really good one, and yes, there are ways in which we could track sort of... I think the question we had is a really good suggestion, and I think there are... Just the only thing, Ruth showed the really fabulous data she was able to use for Greater Manchester. For the purposes of this, we need to have data for the whole of the country, so we can compare to areas that aren't within Greater Manchester. So we can't quite get into the lovely data that Ruth had, but I think following individuals through time will be really important.
Imagine.
Great idea. Great idea. It might catch on. Yeah. Thank you. Question at the back.
Yeah, apology if this is a bit off topic, but as experts in health inequalities, can I ask for your opinion on universal basic income and what impact that could have on life expectancy? If I can.
Yeah, well, the causal evidence about your level of income and your health is very strong. So I think if one of the things you wanted to do was to really address health inequalities, universal basic income is very high up on the list.
Yeah. Does that ever get approached in discussions when you talk about all the significant factors where actually not just ages?
And there is really good ongoing work actually to evaluate the schemes in Scotland and Wales. So I think people are increasingly realising how important that sort of thing is for health. We ourselves have a project looking at universal credit and looking what impact universal credit had on mental health. Now that started off as people were very concerned about what the introduction of universal credit was on mental health. But as you kind of move into a more mature version of the system, actually there is a simplification of the income that you are getting, and that in itself can have some benefit.
Do you see it happening within X and 20 years, 30 years, any?
I wouldn't be an academic if I thought I could achieve that. So.
Thank you.
Thanks very much. Now we've just got one last question down here, the chap in the white shirt. And then I'm afraid you'll have to pick up the speakers at the end when we have canapes and a drink and ask them your more difficult questions on a one-to-one basis. Over to you, sir.
Hello, yeah, Roger O'Brien. I live in West Yorkshire, but only just. And it was a question about co-vaccination, because when I had 4 COVID vaccines, and when I had the last one, I wasn't really given a choice, pretty much. I mean, I opted not to have the flu vaccine, and then I turned up into the surgery, and there were 2 people with 2 different hypodermics, one for one arm, one for the other. And therefore, I'm thinking that it would be interesting to know what different approaches different health authorities have taken, because I wasn't told that co-vaccination was an option. I assumed I would have to go in twice. I said I didn't want to bother with the flu vaccine, and then had one in one arm, one in the other within 30 seconds.
Yeah.
Perhaps not best practice, is it?
No, but I think it's a really important point. I think a lot of people did feel that they didn't have a proper choice and didn't necessarily have informed consent. You weren't necessarily sure what was going to happen when you turned up, and there were times where people were like, in some areas you could have a flu vaccine with a COVID booster, and that was explained in advance, and it was what people were prepared for. But it sounds like in other areas, people were not prepared for that, and it was maybe quite off-putting, maybe put people off having either, and they felt a bit blindsided by it. And I think also in other areas, they said, no, we're not doing co-vaccination. So then that might have led to either less or more of either one or the other. I think it's a very complicated picture, but it doesn't help when the systems aren't coordinated across areas. And I think it's another thing that can just lead to inequalities.
Thank you, Ruth. And I just want to thank all our questioners and the audience, in fact, for coming this evening, because without you, it would have been a bit sad. we were a bit worried about 5:30, 5:45, that nobody was going to come. So we're very grateful that you did. Your questions have been brilliant. I want to thank Ruth and Matt hugely for their fantastic presentations. And I'm sure Dale, I'm going to hand back to Dale now, and I'm sure Dale will invite us to thank them in the usual way right at the end. Dale.
Great, thank you. I'll be very quick. I was thinking that at the COVID inquiry this week, we heard how health inequalities meant that the UK population went into the pandemic sort of ill-prepared and less resilient. And we know that another pandemic is highly likely. So our thanks to Nikki, to Matt and to Ruth for showing that addressing health inequalities is not just prescient, it's urgent. So thank you very much. Round of applause for our speakers. Can I add my thanks to Nikki's for joining us this evening. It's great to see so many of our alumni, our supporters and our donors joining us tonight. Thank you.